Dr Alex Wodak, welcome into the weeds. It's an absolute honour and privilege to have you on.
It's a great privilege to be here. It really is. This is an important subject.
It is an important subject. You're one of Australia's, if not the world's, leading experts on drug and alcohol policy reform. You've been operating in this space for
Too long.
many, many decades, and you've seen significant changes in some areas, good policy and bad policy. But how did you come to be a doctor and specialising in this area of public policy?
Series of accidents. June the 5th, 1981, the Americans announced the arrival of a new epidemic, which we now call HIV or AIDS. It wasn't called that originally. 5 or 6 homosexual men in the United States had this weird new acquired immune deficiency. No one knew where it came from, why they had it, what it was all about. And all sorts of theories were dreamt up. I was in London at the time, and I read about it at breakfast, having my muesli, reading the Times, and never knowing that it would change my life. And so at the time, Mrs. Thatcher was in power in the United Kingdom, and I was keen to leave the United Kingdom for that reason. And I had got a job around about that time at St Vincent's Hospital in Sydney. And we
Inner Sydney Hospital up in Darlinghurst?
Yes, that's right. That's right. And I started at St Vincent's Hospital on the 1st of July 1982. At that stage, we had no cases in Australia that we knew about. Maybe they existed, but we didn't know about them. That came a year or two later. And I got sucked into this vortex of HIV/AIDS because we knew that there were 3 groups at the highest risk. Men who had sex with men, people who sold sex, mainly women, and men and women who injected drugs. They were at the highest risk. And whilst we were horrified by the spread of HIV among them and from them, and we had no treatment, we had no prevention, and the horrible deaths that those people had, particularly the large numbers of men who had sex with men, what we were really terrified of was the spread of HIV from those groups to the huge low-risk general population, the so-called generalised epidemic. Not because one person is more or less valuable than anyone else, because in public health it doesn't work that way, everyone's of equal value, but because we would just be swamped. Once the genie got out of the bottle, putting it back in the bottle would be almost impossible. There would be many, many deaths, many, many hospital admissions, so on. And so people sort of pointed their finger at me. I was the person who was going to control this problem amongst people who injected drugs in the inner city, because that's where the biggest inner city, Sydney, because that's where the biggest population of people who injected drugs was in the whole of Australia. And it geographically overlapped with the people, with men who had sex with men.
And this is in the 80s when, rather than cocaine, there was a lot of heroin on the streets.
Yes.
And so it was the drug of choice, and for people who were taking illicit drugs, there was a lot more heroin, wasn't there? And that's primarily injected.
And male homosexuality was still criminalised in New South Wales at that stage. Wasn't decriminalised in New South Wales until 1984.
So you're trying to manage and deal with 2 cohorts of people who are operating outside the law and hard to reach.
Yes, it was an absolute nightmare.
What a dilemma.
So that's how I got into this. And originally I didn't think it was such a big deal, and I got involved in it clinically before I got involved in it as a kind of prevention policy area.
What does that mean? You got involved.
Well,
You actually treating people with HIV and who'd acquired it through intravenous drug use.
Well, I was doing, in those days, I was also doing some gastroenterology work. So I was asked to and agreed to do gastroenterological investigations on people who were suspected of having the condition that we now call HIV/AIDS. So looking down their mouth into their esophagus, into their gullet, looking into the anus rectum, and looking for different kinds of telltale signs that they had an acquired immune deficiency, which would give different kinds of indications.
I mean, that's courageous work, because at that time there was a lot of hysteria. There was a lot of stigma in the community, wasn't there? There was a lot of panic. Let's call it what it was.
Yes.
There was panic. There was where people were terrified that all of a sudden we had a plague that was going to spill out of the gay and the drug using community into the, as you say, the sort of the much broader, wider population.
Well,
but having doctors who were prepared to go and spend time with these patients was critical, wasn't it?
Look, I didn't enjoy doing that work, to be honest, but it had to be done, and I was on the spot and sort of fell into it by chance and accepted the responsibility to do it. You have to. These people were in a terrible, these patients were in a terrible situation. Somebody had to do it, and I was prepared to do it. I was happy to do, well, can't say I was thrilled to do it, but it's what a doctor does. And so I did that. And then you could see this cascade, this tsunami of an epidemic bearing down on you. And it didn't take me long. And I thought, what needs to be, there'll always be doctors to do the clinical work. But what doctors really need to do is get involved in prevention as fast as possible. And where I can add the greatest value is by getting into prevention as it involves people who inject drugs. And why that's important is that the greatest chance of having a generalised epidemic of HIV in Australia, I thought, and many other people thought, and now it's obvious that's correct, is through people who inject drugs. HIV is spreading from them. And the reason is fairly simple. Men who have sex with men do have sex with women, but not in the numbers that could cause a generalised epidemic. On the other hand, men and women who inject drugs have a lot of sex with men and women who don't inject drugs, and so there's a lot of contact with the general community.
Because some of those are sex workers.
Yes.
So you had like men and women who are injecting drugs.
It's a confusing picture, but yes, basically that's right. So I knew that my responsibility to the community meant that's what I had to do. So I got into that, and a group of us who thought along similar lines started having meetings, and a sympathetic policeman who died recently, Frank Hansen, gave us the name of this group, and he suggested we call it ADDIC, AIDS Drugs Information Collective. So that's what we called it. About half of us were health professionals who wore ties and listened to Bach and Mozart, so on, and half were people who injected drugs, who had purple nail polish and fishnet stockings and so on. But we were absolutely united about what we wanted. We wanted an Australia with no HIV/AIDS or as little HIV/AIDS as possible. And we were absolutely committed. And we looked with envy at the gay groups who overnight had dropped their campaigns for gay decriminalisation and overnight had thrown everything at this epidemic. And they worked 25 hours a day, 8 days a week it was just remarkable. They were absolutely committed, ruthless, just
They were fighting for literally for survival.
Of course they were. Of course they were. But
and so they were fighting not only for good policy outcomes, but also they were fighting a lot of stigma.
And they were seeing their mates dropping dead, horrible deaths. So we wanted to see something matching that in the population of people who inject drugs. That's what we wanted. And we knew that we had to start that process. It wouldn't start automatically.
So what was that process? You had to then become an advocate.
Yes. So unfortunately, it required a lot of people who were health professionals to take that up. And we worked shoulder to shoulder with people who injected drugs, and we became friends and colleagues and collaborated very happily, and we learned from each other, and we got on well, and we learned. I learned so much from that experience, and I learned also that a lot of the things that I was hearing from government officials just simply weren't true, and I learned to not that everything that the people who injected drugs told me were 100% correct, but a lot of it was far more accurate than what I heard from government sources.
So what measures did you adopt? What did you advocate for that were effective in that space?
Well, one of the first things was to free up the availability of needles and syringes, so sterile needles and syringes. That was one of the first things. Another
because the key issue was people reusing.
Yes.
So it was a bloodborne disease.
Yes.
People reusing a syringe.
Yes.
Multiple people using a syringe or syringes,
Yes.
and that was enabling the disease to spread. So clean
absolutely.
syringes and needle exchange programs. These were key policy areas.
And look, Jeremy, I'm not particularly proud of this, but I was absolutely off my rocker in those days. I was obsessed by this. I couldn't sleep at night. I was really so desperately worried about this situation. I had a young family of my own, and I worried what was going to happen to them, but I was worried for the community I was part of. I was worried for the hospital I was part of. So
you weren't Robinson Crusoe being worried. I remember the Grim Reaper ads that came on. I don't know if we'll have to dig those up, Pete, because for anyone born after 1986, 87, they wouldn't have, those ads, I remember seeing them, I was only like 13 or 14, scared the living shit out of me. I thought we had a lot of people thought we had a potential plague on our hands. And
we did have, and those ads were brilliant.
At first, only gays and IV drug users were being killed by AIDS. But now we know every one of us could be devastated by it. The fact is, over 50,000 men, women, and children now carry the AIDS virus. That in 3 years, nearly 2,000 of us will be dead. That if not stopped, it could kill more Australians than World War II. But AIDS can be stopped, and you can help stop it. If you have sex, have just one safe partner, or always use condoms. Always.
Much criticised, and they were risky, but the government was right to run those ads. That's another story. I hope we'll have time to come back to that. But look, this whole discussion is important. So first thing we argued for was increasing the availability. Well, there was no availability of clean needles and syringes. Liberalising the methadone program, which was ridiculously strict. So expanding and liberalising and improving it, which we still need to do 40 years later. But it's a lot better than it was, but it's still, that work is still only half done. And then the third thing we wanted was about education. And we realised that that education was really important, and it had to. There was no point in having university-type words and phrases coming from government ministers and coming from people like me. That what was really needed was street language that had credibility, and it had to be coming from people who injected drugs to people who injected drugs. And, that's a big ask, but that's what was necessary. We had to change behaviour very quickly. Eventually we got those things, but it took a lot of hard work. So a friend of mine was working in the Department of Health at the time, and this is years later, and he was told to clean out a cupboard. And in cleaning out the cupboard, he came across 13 submissions which I had written begging the Department of Health to allow me to start a pilot needle and syringe program. Begging. And each request was declined. Too long, too short, asking for too much money, not asking for enough money, too many references, not enough references. They were just fobbing me off. Eventually, on the 12th of November 1986, I realised that I was never going to get permission, official permission, and I realised I had a choice. The choice was to civil disobedience, or alternatively to let it rip and let the epidemic take its course. And remember, this is the national epicentre of the epidemic, the eastern suburbs of Sydney. And I decided I didn't want to break the law. We're talking about the Drugs Misuse and Trafficking Act 1985. I knew which law we were breaking, and it wasn't just me, but I was clearly there was a group of us. But
You were the tip of the spear.
Yes, I was clearly.
Pardon the pun.
Yes. So 12th of November 1986, I called my colleagues together and I said, we have to do it today. And here's why we have to do it. So we pulled out our wallets and purses. We put our own money in. We didn't take a cent from the hospital or the health department. We used our own money. We found out from the diabetes section where they got their needles and syringes from, because that's the people who inject drugs like diabetic syringes. And we bought one of my friends bought 1,000 diabetic syringes. And that's how it all started, 12th of November 1986. We stuck a paper notice on the door saying, if you want a clean needle and syringe, press the buzzer. That's how it all started.
So civil in defiance of the law,
Yes.
in a major hospital,
Yes.
out there handing out, and was it successful? Did drug users take you
Yes.
up on that offer, and did it work?
Yes, it did. The answer to that is yes, it did. So that day, no one came, but the next day, the buzzer didn't stop, and it hasn't stopped ever since. So we now, in Australia-wide, distribute, exchange something like 40 million, 50 million sterile needles and syringes every year.
Am I mistaken? This was one of the first in the world, wasn't it? Was it the first, or were there other
It wasn't the
jurisdictions?
first.
It was certainly the first in Australia, but
It was the first in Australia.
one of the first in the world.
One of the first. The Netherlands and England were maybe a little bit ahead. And remember, this is England under Mrs. Thatcher. And in England, it was interesting because the Minister for Health had got the similar idea, and he went to Mrs. Thatcher and he said to the Prime Minister, I want to do this. And he said, this is what it'll cost if we do it, named a figure, and this is what it'll cost if we don't do it, named a much bigger figure. And she said, you must do it.
There you go. A conservative.
And I met him a few years ago, about 10 years ago, and shook his hand very happily.
But that was, in a sense, the beginning of it, because that created a public discourse about principally heroin, injecting drug users, and then the conversation about, well, where does our duty of care end? Because we're handing over clean needles and syringes to injecting drug users, but those drug users are then going off to take drugs, sometimes in public places, and overdosing and the rest. So that it created a bigger, expanding conversation, didn't it?
Yeah, we asked the people who took needles and syringes from us to make a donation if they could. 50% of them were prepared to make a donation. These are poor people, and 50% of them are prepared to help us run this program. We ran the program from our own resources, our own personal private resources. I was called in within a day or two to the health department, and I was told to desist immediately. And the chief medical officer, Tony Adams, wonderful, wonderful man, leant over to me and whispered to me, "Keep going." And so I was going to keep going anyway. I said at the meeting that if they stopped me, I would be speaking to the press, and I would explain to people of New South Wales and Australia why I was doing this. And I predicted that the people of Australia would be on my side, not on the government's side. And I knew I was right. So,
did the press get wind of it?
Oh, yes. This was sort of page 1, page 2, page 3 for many, many days. It was a very, very difficult time for me. I wasn't used to that. I'm still not used to that.
You were the spokes.
Yes, I was the spokesperson. And look, it was easier for me than for my colleagues. I mean, it was difficult enough, but it was easier for me being male, doctor, privileged kind of person in a teaching hospital, all of that. If someone else had tried this who was brown, female, gay, nurse, you can imagine how difficult that would have been. She wouldn't have got away with it. I could get away with it given all that I had going for me. I'm not proud of that, but that's how the world works. Privilege, and I think if you've got privileges, you've got to use them. That's how I work.
Well, you certainly did. How long did it take before that program became normalised, formalised, part of the system?
Well, that was November, and I think the cabinet, the police were called in. The police interviewed me, and I was terrified by that experience, the detectives. And there are 4 or 5 of them. And at the end of the meeting, they said, we didn't want to do this, but the minister insisted, which horrified me. And then they said, we're not going to press charges. So as soon as they said that, I knew we'd won, and I knew Cabinet would have to back down. And that's what happened in, I think, December. And then a pharmacy scheme started, which was just the beginnings, and then it's been expanded and expanded and expanded ever since. And then all other states and both territories started, and the whole nation was covered within 2 years. And Jeremy, the answer to your question, your very important question, did it work? Yes, we have had since then, and still have now, an incredibly low rate of HIV among Australians who inject drugs. A very low rate of HIV and a very low rate now of hepatitis B and hepatitis C. And there's no doubt that's because a large part of that is due to the fact that we acted very promptly. And look, it's not, I don't want to attribute everything to just the needle syringe program. We were very lucky to have Dr Neil Blewett as the health minister. He acted very, very wisely.
I mean, the massive campaign around safe sex.
Yes, he was well advised.
I remember having the poster, my mum bringing me the poster as like a 15-year-old of Condom Man.
Yes.
If it's not on, it's not on. There was all the education that went on. It was drummed into us. And
he had great advisors, Bill Botel, great advisors. He had Bill Whittaker, who just died a few months ago, great leadership from the community. And also credit has to go to the opposition, the then opposition. So we had Peter Boehm played a very important role from the opposition, and he had the unenviable job of convincing his leader, John Howard at the time. Wouldn't have been easy, but he managed to do that. So all these people, you know, the credit has to be spread equally, and all of these people deserve enormous credit. And I was at a function in Darling Harbour about 20 years ago, and an AIDS sort of function, and Neil Blewett and Peter Boehm walked into the room, and people cheered and clapped for about 10 minutes non-stop. Just the gratitude to these people.
well, reason and good sense overcoming hysteria and stigma and delivering a good health outcome. But as I was alluding to, it created a conversation about where the duty of care with injecting drug users finished. And so you didn't finish there, did you? You remained in that role of advocating and saying that we had more work to do. And what was that work?
Well, the following year, 1987, I was sitting in my office and I had this kind of eureka moment. I wish I'd recorded the date, but I was sitting there and suddenly this question bore down on me. Why was there such relentless opposition to doing something that to me was so incredibly obvious? You know, here is a life-threatening epidemic which is spreading throughout Australia, spreading throughout the world, and which is a huge health, social and economic threat to the country. And the major way it's going to threaten this country is among and from people who inject drugs. Here is the obvious way to slow it down, and here are people who are trying to stop it. Conservatives. What's it all about? Why are they trying to stop it? And obviously, the answer is these are people who are just addicted to the prohibition of drugs. There's no other answer. And so that day I made a kind of pact to try and understand what is prohibition, does it work, why was it adopted, are there better ways of, or less bad ways of responding to this issue. And so
because prohibition in terms of illicit drugs like heroin, cannabis, cocaine, it hasn't been around forever, has it? It's a child of the sort of the late 19th, 20th century, isn't it? And it hasn't been around forever. And
no,
so
it hasn't. It hasn't.
So
it's
talk to
like,
that.
It's like terra nullius. You know, we haven't had terra nullius forever, as we discovered in 1992, and we haven't had prohibition forever. Prohibition sort of crept in and then has been tightened and tightened and tightened. And it's a good question: why was it adopted? And
is it working?
And is it working? And can it work? And the answers to that are really pretty obvious. Not only does it not work, it can never work. I mean, you know, if you can't prevent drugs like heroin and cocaine and amphetamine getting into the prisons of this world, and you can't, they're in their prisons in the world, how the hell can you stop those drugs from getting into Darlinghurst Road or St Kilda Road or
Western Sydney or wherever?
Wherever. You can't. If a kilogram of heroin costs $1,000 wholesale in Patpong Road in Bangkok and costs $100,000 or $200,000 in Darlinghurst Road in King's Cross or in Soho in London or in Times Square in New York, why isn't it going to make that journey? Of course it is. If you only need 5 containers of cocaine a year to satisfy the US market for cocaine, and you've got, I don't know, 40 million containers of cocaine a year ending up on US ports, and only 2% of them are inspected.
40 million containers
Yeah.
turning up. Only a tiny fraction are actually like looked at by customs. Our borders are porous.
It's about 2%.
2%.
Yeah. And if you're really serious about wanting to ship cocaine or other drugs, you put them in the frozen containers. And when people start to work out ways of dealing with that, then you find some other way. I mean, this is needle in a haystack stuff. Better odds of finding a needle in a haystack than finding the drugs. I mean, 1994, Phillip Street, Sydney, I managed to score a meeting with the Minister for Health, Graham Richardson.
I thought you were going to say something else then. I thought you were about to score something else.
No, I had a meeting.
You scored a meeting.
With the Honourable Graham Richardson, Senator Graham Richardson.
Whatever it takes, Graham Richardson.
And I thought it was my duty to tell him that a career-ending conversation for me, I thought, that look, prohibition can't work. And I took with me a document by a former Coast Guard lieutenant, Stephen E. Flynn. And he used to be the captain of boats off the east coast of the United States, and he'd be sitting there in the swells, going up and down in these Coast Guard boats, sitting there in the moonlight, trying to spot boats coming in laden with drugs. And wondering if he was wasting his time and taxpayers' money, and he decided he would do a PhD on this subject. And he did a brilliant PhD, and it was a very simple idea, and he worked out all the boats and ships and came in on through the Atlantic Ocean onto the Atlantic shores and the Pacific shores, and all the planes and all that entered the United States from wherever, and all the trains and buses and cars and pedestrians that came across from Canada or Mexico. So he worked all that out, and then he worked out what the volume of heroin and cocaine and cannabis and amphetamine and all the drugs were. And he showed very, very simply that trying to stop illicit drugs entering the United States is a complete fantasy, which it is. And if it's a fantasy in the United States, it's a fantasy in every other country.
And they've poured literally, it must be trillions of dollars over decades and decades trying to stop this relentless flow of drugs in various forms, and to no avail. We still have communities like cocaine in Australia now, and fentanyl and other drugs in the US awash.
So I took this document in with me to Senator Richardson, as he then was, and went through it with him. And he was, he's an intelligent man. He was very attentive, listened to it. He had the Director General of the Commonwealth Department of Health with him, and a member of the Anne Simons, a member of the New South Wales Upper House, was there as well. There were four of us. And we went through it all. He asked Senator Richardson asked very intelligent questions. I saw him a few years ago, and he remembers this meeting very well. I guess there are not many people who meet a minister and make career-ending meetings like this. But anyway, I thought it was important to point this out to a minister, that this is a policy that can never work. It really can't.
And that policy, prohibition, in a nutshell, is like listing on a schedule a whole range of drugs we deem to be illicit and banned, and then applying significant criminal sanctions to the production, transportation, and use of those.
Yes, the policy came in slowly and then got added to in bits and pieces, and it came in when China. It started because of China. China was exporting silk, tea, and porcelain, and buying next to nothing in the around about 16th, 17th century, and so it built up a positive trade balance with the rest of the world. And as you know, those positive trade balances over time can cause a lot of political tensions and sometimes lead to war. And this was a big problem for India, which was becoming a colony of Britain, and Britain was establishing the East India Company, a public-private partnership, which was morphing into the British colony, which started in Bengal. So the British were embarrassed by the negative trade balance. So they decided to even it up a little bit by cultivating opium in Bengal and then in other parts of India, and exporting that from the then village of Calcutta to the then village of Hong Kong. And they built specially designed ships that would sail quickly from Calcutta to Hong Kong, and then this all grew very rapidly. But the fly in the ointment was that the Chinese didn't really want Britain to push the opium onto the Chinese through Hong Kong and then up the Pearl River and distribute it like that. The Chinese really didn't want that at all. So that led to growing tension, and then that led to the two opium wars, 1839 and 1856. And then after the...
Which Britain won, didn't they? And but essentially just...
Well, Britain was technologically much more advanced than China, so of course they were always going to win, and to punish the Chinese for their brazen effrontery in standing up to the British, the Chinese seized Hong Kong and the New Territories for 150 years, and look,
forced a massive amount of opium down the Chinese people's throats, essentially.
And what many people don't realise is how the humiliation that China experienced in the 19th century because of those two wars still hurts the Chinese people today, and in the West has largely forgotten this, apart from a few academics who know about this stuff.
I think my great-great-great-grandfather was one of the soldiers that sacked the Forbidden Palace.
Okay.
So it was a catastrophic loss and a loss of face to the Chinese.
Absolutely.
But essentially the beginning of a sort of global drug war, wasn't it?
Well, we in the West are still paying a price for the humiliation that China felt over their loss of face in those two opium wars. So what happened after that was that the British behaved appallingly in China in the 19th century, and the American Christian missionaries reported this back to Washington, D.C., and they were horrified by what they saw. And the Americans didn't do much about it for a while. And then in 1911, they organised a major meeting in Shanghai, in an area that's called the Bund, which is the financial district, in the Cathay Hotel, an Art Deco masterpiece. And there were 13 countries at that meeting. And that was really the first major international meeting about drug prohibition. And it didn't have any repercussions, but it led to other meetings. It led to a meeting in The Hague in 1912, and then a very important meeting in the League of Nations in Geneva in 1925. And that was really a meeting where cannabis was involved for the first time. And also, so 3 plant-based drugs, opium, coca, meaning cocaine, and cannabis were involved in that 1925 meeting.
Because this is before like the advent, the invention really of pharmaceuticals as we know them today. A lot of our they were just sort of emerging at that time, weren't
Correct.
they?
That's right. And then it all went to sleep during the Second World War, and then it got revived under the United Nations, and then all that had been achieved under the League of Nations was rolled together into a single platform called the Single Convention in 1961. And then there were 2 other international treaties, the Convention on Psychotropic Drugs in 1971, and then the Treaty on Drug Trafficking in 1988.
But those UN documents were really pushed by the US, weren't they?
Yes,
behind
they were.
the scenes, it was the FBI, the US government.
Yes.
Through their State Department and coercion and some of their other arms,
Yes,
both internally and externally, that really forced a other countries to sign on.
The Scandinavians were keen on the second of the treaties, which was more about the psychotropic drugs, the synthetic drugs. So that brings us to the current system,
Which because Australia signed on to all of
yes,
all of these treaties.
Almost every country has signed on. And look, it's been very successful. It's been effective. And I think the other element in this whole package has been the politicisation of it by Richard Nixon in 1971. The so-called war on drugs element, and that really worked politically. The only way in which this whole system has worked is politically, and it really has worked well as a political strategy.
So I don't want to put words in your mouth, but what you're saying is that they use the prohibition of illicit drugs, which they've defined, to crack down or to target political opponents. So is that what you're saying? That in particular the Republicans initially in the US targeted people who may have been considered communist or gay or black or environmentalist for drugs, using drugs as a political tool?
Yes, John Ehrlichman claims that he said to Nixon after when Nixon set up the Committee for the Re-election of the President, CREEP, as the acronym for it, very appropriately, that he said to Nixon that the people who voted for you in '68 were elderly, white and wealthy, and they were people who despised young and poor and black people. And if you want to get the elderly, white, wealthy people to come out and vote for you again in '72, what you'll have to do is give them a reason. And if you tell them that you are going to wage a war on drugs, they will understand this as an attack on the young and poor and black. You won't have to say that to them. They will read this as a dog whistle. And Nixon liked that idea. And so this is in a book by Dan Bohm, who interviewed John Ehrlichman. And so that's where we know that this was the thinking behind the whole war on drugs. And it worked. So Nixon won 49 of the 50 states in the '72 election, despite the terrible albatross of the Vietnam War hanging around his neck, because the Vietnam War was a miserable failure at that stage for him. So this was seen around the world as something that politicians should pay attention to. And so politicians around the world realised that if you were standing for election or re-election, you had to have some kind of war on drugs aspect to your campaign. And so lots of people did that.
I know Ronald Reagan, another Republican in the 1980, made it a central part of his platform. I think he may have even, I think his wife, the First Lady, was famous for saying, "Just say no." That was the attitude that all drugs are bad. There's no reason to take them whatsoever, and just say no. And that was a pretty powerful message that was heard around the world.
I think a lot of the centre-left parties around the world also cottoned onto this, and whether they believed or not, I've no idea, but they certainly...
they didn't push back.
They didn't. No, they didn't. That really, the pushback against the war on drugs was very slow to come.
So that pushback sort of came out of the long failure of prohibition and then the HIV. So in the sort of 1990s, people started to talk about, well, look, you've had decades of this policy. We've got people overdosing from drugs. Drugs are pervasive in society. They're still widely used. There's enormous harm when they're misused. So there was conversations emerged about some of the alternatives.
Yes, and look, we still have this deeply entrenched sort of setting for prohibition policies, and we can see it in Australia today with Labor governments and their preference for the way they're responding to vaping. I mean, for goodness sake, here we have 8 million people around the world killed by cigarette smoke, 21,000 a year in Australia, and we have no deaths, as far as we can tell, from vaping nicotine. And what does Australia do? Make vaping nicotine as hard to get as possible. And if you want cigarettes, no, that's not a problem. You can, if you're an Australian adult, you can get them anywhere.
Well, it's worse than that, isn't it? Actually, they've made vapes almost unobtainable.
Absolutely,
they've essentially a complete prohibition on it, apart from a few sort of schemes that aren't working through pharmacies, and then they've jacked up the excise on tobacco, so to the point where there's this just massive black market in tobacco, and everyone's going from vapes not to regulated tobacco, but cheap tobacco from China and Pakistan.
And so we're in this ridiculous situation where a lot of people from tobacco control in Australia and public health and around the world have sort of swapped places with big tobacco. So big tobacco, who decade after decade after decade lied through their teeth without any qualms at all. And then these days we have ministers, government officials, tobacco control, public health, lying through their teeth about vaping, saying things that they must know are simply not true.
And they've got this, so much. Tobacco is the obvious example where they knew, they clearly knew for decades that it was linked to literally thousands of types of way to become unwell. They knew that about tobacco and hit it, yet didn't prohibit tobacco. They allowed tobacco to roll out. And look at the so why is it that tobacco and when we look at alcohol, why is it that they haven't prohibited those things and regulate them?
Well, there have been lots of attempts to prohibit alcohol, including in Australia. So don't forget that Australia did prohibit alcohol for Aboriginal people from the 1860s to round about the 1970s. So if you're a First Nation Australian between the 1860s, thereabouts, to the 1970s, you couldn't buy alcohol. Remember Albert Namatjira, who was made a kind of honorary white Australian, was allowed to buy alcohol.
Really had his special permission for alcohol.
Yes, and so he got caught between customary law, where he was required to share what he had with his kith and kin, but the white man's law said he wasn't allowed to share alcohol. So for him, customary law was more important than white man's law. And so he kept on going in and out of prison because he disobeyed white man's law. And so that put this whole prohibition of alcohol for First Nation Australians into some disrepute. So we had alcohol prohibition in Australia. Don't kid yourself about that. And of course, they had it in the United States from 1920 to 1933, and many countries around the world have toyed with alcohol prohibition. Many states in India have had alcohol prohibition and tried it more than once.
But all of them are failure. Ultimately, alcohol was still available, made a lot of people in the black market very rich.
Yes, that's true. And also, you have to remember that terms like prohibition are very slippery. They're very, they sound like they mean something very specific, but actually they don't. So Winston Churchill arrives in the United States during alcohol prohibition, but actually he brings with him a letter that says, the bearer of this letter, Winston S. Churchill, needs to have alcohol for medical reasons, and please provide him with. And we have a copy of that letter.
Champagne for breakfast, I think, was Winston's go.
So Winston was able, because of his connections in his class, to have legal alcohol, and in Iran, the ban on alcohol, if I'm not mistaken, is for Muslims, but the ban does not extend to non-Muslims, and Muslims constitute over 90% of the population in Iran, but still for the 8 or so percent of the population who are not Islamic, they're allowed to have alcohol, and they can get alcohol in Iran.
So prohibition certainly has not been a spectacular success wherever it's applied, especially in terms of public policy and health outcomes. So am I right that in the 1990s people started to talk about dealing with drugs, be they legal drugs, alcohol and tobacco, much more focused on, and illicit drugs, focused on those issues through a health lens?
Look, if there is strong demand for a good or a service, for that matter, like sex, same thing applies. If it's difficult to control that good or service, then you've got Buckley's chance of making it a success. But sometimes you've got a commodity that where the demand is weak and where it's easy to control the commodity, and also where the replacement commodity isn't all that bad, and where prohibition can work. So I know that people often say prohibition never works. Rarely it does. Now, I know I'm a kind of academic, wonky kind of guy, but...
well, you're not dealing in absolutes, so that's important to know, that in some conditions, that it doesn't work. But in the 1990s, people really started to look at alternatives. There were some European nations that were looking at alternatives to how they dealt, especially with the heroin epidemic, as it was framed. And we in Australia, we were sort of dragged, especially in New South Wales, into a major drug summit in New South Wales in 1999 that you were a key part of. Can you talk to that?
I'll do that in a moment. I just want to finish on this, so that in the 50s, 60s, maybe before your time, so we had every office and factory in Australia had cabinets with APC tablets, aspirin, phenacid and caffeine in them, and people used to raid these boxes and gobble these tablets down. And we had an epidemic of kidney failure, which was, and it was traced to these tablets. And so these tablets were banned and prohibited. And around about the same time, people used to take them for God knows why, but about the same time, Valium started coming in. And Valium's not harmless by any means, but the harms aren't doesn't cause kidney failure. So we swapped APC for Valium, not intentionally, but that's what actually happened. So demand for APC was weak. Controls were easy to impose, and they worked. And the replacement drug wasn't as bad as the prohibited drug. So sometimes prohibition works and is worth doing, but most of the time, like 99.9% of the time, prohibitions fail miserably. So, but they work politically. That's the problem. That's the real problem. And that's where people with your skills and your ability are important. Now, why drug summits?
They work until it's obvious that they're not working. So in the current situation in Sydney, it's just clear that the society's awash with cocaine. It's available everywhere. We've got this very violent gang war erupting on the streets of Sydney, fighting over control of the incredibly lucrative drug trade. So that evidence is hard for politicians to ignore. And the same we were in a very similar situation in the 1990s when it came to heroin, weren't we?
We were, and where I think where I think the problem I have with the drug summits is I don't think we have enough of them. We don't do it often enough. We had a Royal Commission or a major inquiry into drugs, about one a year in Australia for about 30 years. Very expensive, and the dividend was very small. It's not a great way to change drug policy. We've had millions of parliamentary inquiries. Seems like a good way to change drug policy, but I don't think it's changed a lot of drug policy. I think drug summits are a much more effective way of changing drug policy, and I like the idea of people from different backgrounds getting around a table and hammering things out. And I like the idea of people who have different ideas and saying, no, you're not right to say that. And look, my next door neighbour had this, or bring up evidence, challenging ideas, challenging backgrounds. So I think the 1999 Drug Summit was hugely important, and one of the reasons it was hugely important, frankly, if you don't mind me saying this, is that I think a lot of members of Parliament know next to nothing about drugs, really. They learn about drugs from the Daily Telegraph. And there was a chalk and cheese difference about the discussion in Parliament before or after the 99 Drug Summit. For a few years, they really did understand the issues much, much better. It sort of washed off after a while.
Well, just walk us through it. What were the mechanics? Because it's quite in terms of drug law reform, that summit is often pointed to as, a spectacular success.
It was a spectacular success.
What were the mechanics of it? What actually happened physically? Who was there? Where was it? How did it work?
Well, it was in Parliament House for 5 days, and I think all the members of Parliament were there, as far as I remember, and there were maybe 80, 100 non-parliamentarians also there, and so our side, the reform side, were lucky to have gay guys who are very good at and very used to lobbying and know how to do that. And so they would run around and do our lobbying for us, because I don't know how to do all that. So they would go to left-wing Labor, and then they'd talk to right-wing Labor, and then they'd talk to, I don't know, someone else. And they would come back and check with us, and then they were doing all that in the background all the time.
So the issues around drug use and misuse and were being laid out on the floor of the Parliament by community advocates, people with lived experience.
Yes.
And behind the scenes, you had people, talking to the various decision makers about what could be done.
Yes, and we also had people like John de la Bosca, a person who I don't know that well. I know him quite well. And I have the highest regard for him. And he, whenever I've spoken to him, he always seems so reasonable, talks a lot of sense, both feet on the ground. And he had the respect and the ear of the Premier.
He was a minister at the time?
Yes, and he seemed to have a senior advisory role to Bob Carr.
The Premier of New South Wales at that time.
Yes, and look, Bob Carr went into the drug summit very, and this was public knowledge, was very traumatised by his own family's experience, where his brother had a heroin overdose, and his ageing parents, he didn't die from the overdose, but he never recovered consciousness, and he was in the hospice across the road from St Vincent's Hospital, and his ageing parents came every day and saw him, and it tore them to shreds. And Bob Carr never forgave his brother for that, putting his ageing parents through that, which is understandable. And it took a tremendous emotional toll on Mr. Carr.
And yet he still was able to put the broader public interest first, and to have those difficult conversations in a forum that the Parliament, which couldn't be ignored.
He made it clear that was a real difficulty for him. But I think over time he's moved on from that, and so he eventually listened to the arguments. And look, when you heard the arguments at the drug summit, the 1999 drug summit, for and against the medically supervised injecting centre, really I don't know how anyone could still oppose the medically supervised injecting centre. And when you see the results that have happened, surely it's no surprise that the results have been so spectacularly positive.
So walk us through it. The medically supervised injecting centre, it's on Darlinghurst Road in King's Cross.
Yes.
And it was a world first.
No, it wasn't.
Wasn't it?
No.
Again, I'm wrong.
You're really wrong. No, the first was in 1986 in the Swiss federal capital in Bern, where Einstein rode the tram that made him think of the theory of relativity. So that's where the first one was, and there's still a medically supervised injecting centre. They don't use that ridiculous terminology there. They've now got in Bern a separate injecting room and an inhalation room, because quite rightly they want to push people to go down the inhalation path away from injecting, which is inherently dangerous, and much better to move people who are ready to inhale rather than inject. So in many European cities now, they've got inhalation rooms as well, or instead of injecting rooms.
So why an injecting room? Why was it important? We've had the AIDS epidemic.
Okay.
We're now got needle exchange programs. What is it about a medically supervised injecting room that's good public policy?
Well, Why is it important? And why was it important then? And why was it important there? Well, at the time we had sky-high rates of heroin overdose deaths, and we're almost at the same level right now. Our overdose death rates are frighteningly high, not quite as high as they were in the late 1990s, but getting up there, and we're awfully dangerously exposed to going back to even higher levels because of the contamination of the drug supply that's happened in North America and a little bit in Europe with fentanyl and other drugs.
Nitazines.
Yeah. So if that happens in Australia, it's happened, but not on the scale of North America. If that happens in that scale, it'll be diabolically difficult to.
So we've got cause to pay attention to what happened at the medically supervised injecting centre.
Yes.
What happened? Was it a success?
Yes, it was.
How does it operate, and why was it a success?
So we've got around about 2,000 drug overdose deaths a year in Australia, a bit over, I think, and in the late 1990s, about half of those deaths were in New South Wales, and many of those deaths in New South Wales occurred within a 2-kilometre radius of King's Cross, because King's Cross is a major distribution hub. So we needed to bring down the rate of deaths, and we needed to also have a local answer in the King's Cross area, and we needed to act quickly. So they were all the reasons why we needed to have a medically supervised injecting centre, and it had to be in King's Cross. So that's why.
And that was one of the key arguments of the drug summit.
Yes.
And the government responded and said yes.
Well,
Ultimately,
it began with the Wood Royal Commission in 1997, and Justice James Wood said that this is something that Parliament should consider. Very properly, he didn't try and make public policy. He said Parliament might like to consider this. So Parliament set up a committee of 10 members, and they wrote an excellent report, which, when you read the text is very clear and is very supportive of a medically supervised injecting centre. And then they came to vote on it, and the vote was 6-4 against, and clearly what had happened was that the members of the committee had disobeyed the standing orders of the Parliament and listened to and had obeyed the instructions of their political parties. Now, I don't know whether this is something that often happens or rarely happens.
often happens. It does happen.
Okay, well, it was a terrible shame. So, so that happened in 1998, and so a group of us started meeting in 1998, and we met quietly, secretly, and to set up a medically supervised injecting centre in the basement of the Wayside Chapel, and that was spearheaded by the late Reverend Ray Richmond. Wonderful man, wonderful man. And he was sick and tired of stepping over dead bodies and conducting funeral services for people who died of drug overdoses, and he wanted an answer to it. He didn't want more funerals, and so we started planning for that. And then in January 1999, the then Deputy Premier, Minister for Health, Andrew Rafshorgi, gave an unfortunate interview to the Daily Telegraph where, in answer to a maybe trick question about a photograph of a young Aboriginal boy in Caroline Lane in Redfern, about a young boy injecting, the Minister for Health said something about the Department of Health's needle and syringe program that wasn't correct. And so the media was obsessed by this for the next 48 hours. And then in order to look over there, the Premier said, if we're re-elected in the elections in March, we'll have a drug summit. And so we had a drug summit. And so the attention given to the Deputy Premier's media mistake was forgotten. And we started talking about the drug summit. And then the Premier said, but we've already dealt with the medically supervised injecting centres, so that won't be part of the drug summit. So we started operating the drug summit in the Wayside Chapel.
The injecting centre in the Wayside Chapel.
Yes.
Again, like going outside the law.
I wouldn't put it in those terms. I would call it civil disobedience.
Civil disobedience.
But look, I can't say I enjoy doing that, but it's something we had to resort to, you know.
And so what does it mean? What does it mean, a medically supervised injecting centre? So people can
we
arrive with illicit drugs, and what happens? Because it's still in operation, isn't it?
Well, no, this was in the basement of the
Oh, this is in the
Wayside
basement. Sorry, yes.
Yeah, and
so walk us through how it ended up on Darlinghurst Road.
Look, this had been discussed by the board of the Wayside Chapel, and the board of the Wayside Chapel at that stage included a former federal Liberal Party federal Attorney General who also approved the Wayside Chapel doing this. So it's pretty serious stuff. And so we did this. So police raided the premises several times. They arrested three people who injected drugs on the premises. They charged the Reverend Ray Richmond. I attended his court hearing in the Downing Street Centre, and the magistrate in the Downing Street Centre threw all 4 cases out with contempt, I'm pleased to say. I mean, they shouldn't have been charged. It's ridiculous. The other thing I'm pleased to say is that during one of those times when we had, when the centre was in operation, some gay group was meeting in Sydney, and they marched in solidarity with what we were doing. And that was a very touching, moving experience. There maybe were 100 of them, 150 of them, and they previously hadn't shown a lot of solidarity with the drug user movement, but they did that day. So there were a lot of parents who were involved, parents of drug users, some nurses who were involved. So we had equipment, we had the sort of equipment that's in the legal medically supervised injecting centre, and it was a very difficult time for me, but of course it was every day is a difficult day for the people who inject drugs.
So how did it come to pass that there was legislation enacted that set up, that formalised, that took it out of the basement of the wayside chapel and into a dedicated premises?
There was, I was told that there was a meeting that had come to an agreement that if we stopped the operation of the civil disobedience injecting centre, that it would go back on the agenda of the drug meeting in May, and so we stopped operating the Wayside Chapel centre, and it was discussed at the drug law reform meeting in May, and it was passed. It was very, very moving, that discussion, and full credit to John Brogden also, who was so courageous in, he was under a lot of pressure at the time, and there was a lot of attention paid to him when he voted in favour of the medically supervised injecting centre.
Because it's a funny piece of legislation, because what it does is essentially carve the state, that premises out from the state's drug laws, doesn't it? It basically creates a little Switzerland or a Vatican or whatever, however you want to describe it, that's not subject to the state's drug laws. So people can possess drugs there, they can use their drugs there, and they're not subject to criminal sanction.
Yes, and look, we have now more and more of these centres being set up around the world, and almost all of them are very successful. A few don't work, but almost all of them are very successful.
And what is successful? You've got a doctor there who stops, and others who stop people dying, don't they? If someone overdoses, I mean, how many people have had their lives saved because rather than take their drugs in a stairwell or a toilet or behind a bus stop, they've done it in the injecting centre. Would it be thousands?
There would be. Well, these centres operate around the world. There are about 150 or 200 of them in cities in many cities in Europe, in Canada, in the Netherlands, in Switzerland, in France, all over the place. So the number, it's hard to estimate how many lives they've saved, but there hasn't been a death from drugs in one of these centres anywhere in the world. One person died of asthma or something. I can't remember exactly what they died of, but it wasn't drugs, and that's all. So they've been extraordinarily successful. And the other thing is that they've been, apart from the deaths, a lot of people go there and get help with other things. So they start going there, and they get help for female reproductive issues. They get help for primary health care. They get help for drug treatment. They get help
housing, whatever.
legal issues. So that they're and I've seen research on the kind of people who go to these medically supervised injecting centres, and many of these people are incredibly depressed. They've had, half a dozen suicide attempts in the last year, that sort of thing. It's really remarkable how important they are, and the opposition to them is insane. It doesn't make sense. And the people who work in those centres are angels. They really are.
I visited the one in King's Cross. They really are. I mean, you talk about frontline health services. Yeah, the doctors there are absolutely amazing. Look, there's been a lot of discussion about alternatives to prohibition and using the Crimes Act to try and deter people from using illicit drugs. But humans have always used drugs, will continue to use the various drugs. At the moment, there's a big discussion about how sort of there's been a liberalisation. They've moved to a decriminalisation model in parts of the US, and there's a suggestion that it hasn't been a success. Yet we've got other jurisdictions like Portugal and parts of Europe where they've brought in liberalisation and reform that seems to be working. Why the difference? Could you comment on that?
Look, overall, I think wherever we've seen drugs handled less restrictively, overall, it generally has worked. I mean, there's no magic in all of this. You can always muck things up if you really try to muck it up. And I think we have to realise also that when you haven't done something before and you start doing it for the first time, there are going to be some lessons you're going to have to learn. And that applies to this issue of cannabis as well. When we start regulating recreational cannabis in Australia, I assume we'll make mistakes and we'll get better at it. We'll be doing it better after a year or two than we do straight away. And we'll be doing it better after 5 years than we do after 2 years. That's with everything. And also, some drugs are easier to regulate than other drugs. And we'd be silly to start regulating the more difficult drugs like heroin and cocaine. We should start with the easier drugs like cannabis and MDMA and psilocybin. They're the drugs we should start with. And we shouldn't do it all at once. We should do a little bit at a time, and then when we've got that one sorted, or those few sorted, then move on and do other ones. It's not that complicated. And I think we should sit down and reason with the people who want it all sorted by midnight tonight. That's not the way the world works. So I'm going to the Harm Reduction International meeting in Bogota in Colombia in April. I think there's a good chance that President Gustavo Petro of Colombia who is keen to regulate cocaine for good reasons. It's a big mess in his country. I expect he will be saying something at that conference about regulating cocaine in Colombia at that conference. And, that's an important reminder, because you might think, Jeremy, that drug policy creates real harm in our rich country, and it does, but it's nothing compared to the harm that prohibition causes in the production countries and the transit countries. Colombia, Bolivia, Peru, Afghanistan,
Burma, places like this.
Yeah, exactly. Mexico. These countries are just destroyed by their prohibition policy. And people in the rich countries have no realisation of what that's like. They don't. I don't know whether they don't know or don't care, or it's a bit of both. But I go to some of those countries, and it's shocking how the impact that has on so many people.
That's truly interesting. Well, I'll be interested to hear how things go in Bogota. Look, before we go, I wanted to ask you about addiction. What is addiction? Because we've, I've, I think that there's a perception in the community that addiction to drugs is a physical addiction. That people and it can be, but it's a lot more than that, isn't it? I'd like to get your views on what is addiction. What are the causes of addiction? Is it just because we become dependent on a drug, or is it because we're missing something else?
I don't particularly like the term addiction because it's got so much stigmatizing baggage attached to it. So personally, I don't use the term unless a patient by preference, uses that term. I use the term dependence, which is, I think, a little bit less affected by all of that. So for me, it's a biopsychosocial issue. So there are biological, psychological, and social aspects to it. Well, that sounds a bit nerdy and wonky, but bear with me. So I think there's a lot of truth in the lay way of looking at this, that a cardinal aspect of drug dependence is continuing use despite severe adverse consequences. Now that's actually a key element of most of the scientific definitions of dependence. There are other aspects as well, but I think it's right to look at that as a key driving force. But what I think we can see with dependence is that people do keep on using a drug even when it is clearly harming them or their loved ones or their others close to them. Now, one of the problems I have with dependence is that a lot of the harm that comes from drug use comes despite dependence. So people can use prodigious quantities of a drug without being dependent on that drug and get into all sorts of trouble from the drug. So yes, dependence is important, but also sporadic prodigious use can also be very dangerous. So we don't want to make everything to do with drugs labelled drug dependence. In terms of drugs like nicotine, yes, clearly its dependence is the driving factor there. But with alcohol, we see both things important. We see the explosive sudden use can be very dangerous, very damaging, and we see that continuous use, slow use over time, being associated with dependence, being very dangerous.
What's your view on some of the methamphetamines, ice that we're seeing? Like, can there ever be like a safe level of use of that? Like, is that a drug that we should really try and prohibit, or how best do you regulate a drug that can have such adverse impacts on the individual and especially on their behaviours?
Well, I think for me, methamphetamine is an example of, and all of different formulations of it, is an example of how damaging prohibition has been, because it's really been, prohibition's been a driving force in developing an increasing range of different types of drugs, and also the more recently developed new types of drugs are much more dangerous than drugs that were 20 or 30 or 40 or 50 years old. And if we look, for example...
So what I think you're saying is if we hadn't have had such a
Yes.
restrictive, prohibitive approach to, say, like opiates, cannabis and the like, or cocaine, we may not have had the emergence of these synthesized and highly problematic drugs.
Definitely. And we see that very clearly with cocaine, that it was when people use cocaine leaf, they don't get into trouble, and cocaine has been used in South America. We know at least since the 1100s, maybe even earlier in South America, by indigenous people, and we know that from statues where there's a lump in their cheeks. So we know, and that's how they use it today. So we assume that's why there's a lump in their cheek. And there's hardly any evidence that causes any harm whatsoever. And then what happened is that as the law enforcement pressure on cocaine increased, there was an ever-increasing desire to make cocaine more and more concentrated. So they went from coca leaf to busaco, the paste, and then they went to powder forms, and then they went to crack. And each time they ramped it up so that it had more pharmacological kick to it, so it became more and more concentrated, so that a 1 cubic centimetre of the drug had more potency, and there was greater and greater risk, and that's exactly what's happened. And there were still already problems when powder cocaine was a problem, in Sigmund Freud's day, when his career was starting off with his friend William Fleece. So that was in the 1870s, 1880s, somewhere around about there, 1884. So there were already some problems there, but the problems have really grown exponentially since then because of the law enforcement pressure. And what happens is that people learn about the problems with methamphetamines or whatever the problem drug is, and then people forget about it, and then they forget about it for a generation or two, and then the drug comes back. So prohibition really has been a public policy disaster. And we haven't yet figured out a way of really moving on beyond that. And I look at the success of moving on from another prohibition, which was the prohibition on homosexuality. And for me, that's really a very positive lesson, because we had centuries, millennia of prohibition of same-sex sex. And we've really just managed to get over that. Not quite, but there's light at the end of the tunnel. That movement is now moving throughout the world. So most of the rich countries have completed that, are close to completing that process. It's now moving into some of the low and middle income countries. But for me, that's really the model of what we really need to do with, I appreciate that there Some people might take exception to me seeing comparisons there. Appreciate there are significant differences, but there are some significant parallels. The terrible stigmatization and the blackmail and terrible torment that homosexual men and women had to go through over centuries. And there are some parallels with what people who use drugs go through still today. And we're just at the beginning, I think, of trying to unravel that.
Well, Dr. Alex Wodak, that is a positive way to end this discussion. I really appreciate you coming on the podcast and for the courageous work that you have undertaken for the betterment of the people of New South Wales and Australia in terms of your work as a doctor and as an advocate for those people impacted by drugs and drug use. A rational and reasonable voice, as always. Thank you, Dr. Wodak, for coming into the weeds.
Thank you, Jeremy. Thank you. And look, I wish you and your colleagues in the Legalised Cannabis Party all the best. And I can't wait to see cannabis regulated and taxed and treated like just another commodity. Can't wait for that. Should have happened 30, 40, 50 years ago.
Here. Thanks, Alex.
Okay. Good.